Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hi, I'm Dr. Eileen Scully, an Associate Professor of Medicine at Johns Hopkins University, and welcome to Clinical Clips from CROI 2025. This is episode 1 of 4. So to start off this really exciting conference today, we'll talk a little bit about some findings in hepatitis. So the first is abstract 108. This looked at trends in hepatitis C virus infection incidence across people with HIV who are engaged in care in the United States between 1995 and 2023. So this presentation uses data from the CNIX cohort covering between 1995 and 2023, and it sought to address the trajectory in HCV incidence across different populations who are at risk for HIV acquisition for different reasons. So of the 1,276 incident cases, the highest rates were in people with injection drug use at an incidence ratio of 28.2, or men who have sex with men who also have injection drug use at 20.4. And they were higher overall in men who have sex with men without injection drug use than in heterosexual people with HIV. Notably, this was really the most striking finding, this more than twofold increase in the incidence of hepatitis C in men who have sex with men who do not have injection drug use between the first period of treatment and the last period of treatment, now coming up to 2023, suggests that we really need further work to understand the drivers of this increase in acquisition. The next abstract in relevance to hepatitis is abstract 112, a late breaker. So in this, we looked at highly durable seroprotection with the hepatitis B CpG vaccine. This is built on the results from the ACTG A5379 Beehive study. There's already demonstrated that the CpG adjuvanted hepatitis B vaccine had really remarkable efficacy in comparison to the alum adjuvanted hepatitis B vaccine platforms. And in this assessment of durability of protection, they found that the CpG adjuvanted 3-dose vaccine was the most durable, the 2-dose vaccine a bit more durable than that, and both of those were greater than the alum adjuvanted hepatitis B vaccine at week 72 after completion of the study. So this is yet another piece of data supporting the high efficacy of this CpG adjuvanted vaccine. Okay, now let's shift gears a little bit and we'll talk about adolescents and the use of lenacapavir for prevention of HIV. So this was a sub-analysis of the results of the Purpose 1 study. In this particular presentation, they were highlighting that during that study, they enrolled 16 and 17-year-old adolescents. So they did this by engaging a bunch of different important stakeholders, including the community and regulators, and found novel ways to include this population that is at high risk and is often in delayed receipt of new therapeutics. So what they found in this analysis was that in individuals who were over 35 kilograms and between ages 16 and 17, there were 124 adolescents, 56 of whom were assigned to the lenacapavir group, and they had overall similar pharmacokinetics to the adult participants and no significant differences in adverse effects. There were no seroconversions in any of the lenacapavir recipients, including these adolescents. And this trial just really marks a new phase for the inclusion of adolescents in trials and in how we can further enhance the speed with which we can deliver therapeutics to this group who remains at high risk of HIV acquisition and yet has often had delays in receipt of novel treatments. Next is abstract 121. This was a really fascinating study presented by Michelle Yang that was looking at interruptions in treatment and mortality among children living with HIV under 15 years old in 53 PEPFAR-supported countries between 2021 and 2024. So of note, children represent about 3% of the global people living with HIV, but account for 12% of deaths. So in this study, they sought to address interruptions in treatment in children less than 15 using the monitoring and evaluation and reporting data from PEPFAR. And then they assessed the timing of the interruption in relation to the initiation of ART, and also assessed whether or not there was a return to treatment and what the rates of that event were in the same population. They then looked at mortality and classified mortality as HIV-related or other natural causes or non-natural or non-reported causes. So there were more than 500,000 children in ART in these PEPFAR-supported countries. And among those children, there were more than 21,000 interruptions in care during the study period. In most children with an unexplained interruption in treatment, the timing was typically more than 6 months after the initiation of ART, with the exception of the age group of less than 1 year, when it occurred within 3 months of initiation in most cases. The investigators also looked at the causes of death in this group, and among the 22% for whom there was available mortality data, they found that HIV-related mortality really accounted for more than half of the deaths in these children. So there are some limitations to this study. It does not have individual level data, and there may have been silent transfers, and there's a substantial amount of incomplete data. But overall, the study of more than 500,000 children in PEPFAR-supported countries highlights the patterns of interruptions in clinical care and the continued significant risk of HIV-related mortality in young children. So now I'd like to just briefly talk about a couple of studies, all of which focused on semaglutide. So these studies were from a group of posters on the Slim Liver study, ACTG study A5379. This study enrolled people with HIV who were over 18 years of age on stable ART for more than 6 months with suppressed HIV and an elevated waist circumference. And previously, the study has shown that during the 24 weeks of semaglutide treatment, there was a significant weight loss and reduction in insulin resistance as well. In poster 861, the investigators described the cardiometabolic risk profile in study participants, showing significant improvement in multiple biomarkers in the plasma at week 24, decreases in weight, waist circumference, and a 25% reduction in the metabolic syndrome. The investigators also demonstrated that the majority of participants who lost weight did regain the weight, approximately 75% of the lost weight, and that this was accompanied by other unfavorable metabolic profile changes. In poster 757, a OW liver metabolomics profile based on liquid chromatography and mass spec that has previously been validated against liver biopsy was used to show that among the participants who lost weight, there was some improvement in about 1/3 of the participants in their classification using this metabolomic profile, again, identifying a significant benefit of this treatment. And then finally, in poster 759, the investigators analyzed the impact of semaglutide on the microbiome, showing that both the baseline profile of the microbiome and changes that were observed after initiation of the treatment may be associated with some of the favorable outcomes in liver triglycerides. So taken together, there's a strong argument that semaglutide may be part of the suite of options that we will offer to people living with HIV with certain metabolic conditions. One other study I'd like to talk a little bit about was one done specifically in pregnant women. So it's known that the highest risk for TB reactivation occurs during or right after pregnancy, and also that many women who are at risk of developing active TB disease who have latent or inactive TB are of childbearing age. However, there are very few interventions to reduce the risk of reactivation disease. And while the current WHO and US CDC guidelines recommend the use of INH preventive therapy in pregnant women, there's a study, the APRISE data, that indicates that there may be an increased risk of adverse outcomes if you have more than 6 months of INH treatment in pregnant versus postpartum women. And current South African national guidelines actually recommend against INH therapy during pregnancy, but suggest deferring that to postpartum. So thus, there's a really strong need for alternative TB preventive strategies during pregnancy and a need to assess ART in the context of those regimens. So the Dolphin Mom study specifically was an open label phase 2 trial that enrolled 50 pregnant women between 20 and 34 weeks of gestation with HIV suppression on a dolutegravir-based antiretroviral therapy regimen and randomized them 1-to-1 to either receive 1 HP, which is daily INH 300 and rifapentine 600 milligrams for 1 month, or 3 HP, which is weekly INH at 900 and rifapentine at 900 for 3 months. And both groups were receiving twice-a-day dolutegravir. Overall, this study demonstrated that there were no differences at day 1, but at day 17 there was a significant decline in the dolutegravir trough concentration in both arms. These levels remained stable at day 52. And simulation analyses suggested that dolutegravir can be given twice a day with 1 HP, but that this likely can be used only once a day with 3 HP. The investigators have enrolled a subsequent cohort of 25 additional pregnant women and are actually currently testing whether 3 HP and once daily dolutegravir will actually achieve the therapeutic concentrations. So this important study will hopefully give us the information we need to better guide preventive therapies in this population. And then finally, I'll just briefly comment on the late-breaking poster 658. So this was a European investigator-initiated open-label, multi-center, non-inferiority trial comparing people with advanced HIV at treatment initiation who are randomized 1-to-1 to either bictegravir FTC-TAF or darunavir-CoB FTC-TAF for 48 weeks. This trial was aimed to specifically address the fact that most registrational trials have only a minority of participants with advanced HIV disease, and their primary outcome was time to failure. So they enrolled 442 participants and randomized them 1-to-1. The majority were male at 81% and white at 62%, but they had almost 86% with a CD4 count of less than 100 and 45% with a viral load greater than 500,000. The overall results demonstrated that BIC-F-TAF was non-inferior to darunavir-CoB F-TAF for their composite outcome, but the BIC-F-TAF arm actually showed better virologic response at week 48 and fewer adverse events. An important study that shows that although those participants represent the minority enrolled in many of the initial clinical trials, that these regimens have really excellent efficacy for those participants. Thank you so much for joining us here for episode 1. Please refer to the landing page for slides and to claim your continuing medical education credit. And please be sure to come back tomorrow for our second clinical clip from CROI 2025.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.